Hello, everyone, and welcome to this next episode of the Akkad and Coca Report. I'm Michel Akkad in San Francisco, and joining me from Philadelphia is my co-host, Dr. Anish Coca. Our topic today can only be of great interest, not just to physicians in our audience, but to anyone who is concerned about the mental health of doctors. We will be talking about physician burnout, which has risen to the fore of public health issues in recent years. Physician burnout has attained epidemic proportions. It is highest among all professions, and new research indicates that doctors commit suicide at a rate that is twice that of the general population, leading to a loss of approximately one physician per day in the United States. And it's not only doctors who are at risk, patients too may suffer the consequences, as medical errors have now been linked to the issue of physician depression and burnout. What the actual cause or causes of this epidemic are remains a hotly contested topic. But with us are two distinguished guests who have recently published a highly provocative essay in Stat News, an essay whose thesis has resonated with many doctors who have sensed an insight that may have been ignored in the more mainstream narratives and theories about the burnout epidemic. Wendy Dean is a psychiatrist who is Senior Vice President of Program Operations at the Henry M. Jackson Foundation for the Advancement of Military Medicine. And Simon Talbot is an associate professor of surgery at Harvard Medical School in the Brigham Hospital's Division of Plastic Surgery. Wendy and Simon, welcome to the show.
Thank you. It's good to be here.
Okay, so we'll let me ask you maybe one at a time. Perhaps you, Wendy, to tell us a little bit how you became interested in this issue of burnout, because I don't think neither you nor Simon are in academia, occupied with publishing or writing about burnout, and then I realized that I'm using the term burnout, which you have some disagreement with in your piece, but I'm using it right now because it's what people commonly associate. It's the term that people commonly associate when they talk about these issues. And so, Wendy, what got you to be interested in physician burnout?
So I have been working in military medicine for the past 9 years, supporting military medical research. And in the process of that, one of the most prominent funding programs has been in suicide prevention in the military, because there was a big campaign where the leadership in the military recognized that suicide in active duty military and recent veterans was substantially higher than the general population. And I started thinking about, I read about a physician suicide, and it started me thinking, I wonder how that compares, because it's also a high stress field. It's a field where you lose people on a regular basis. And when I did the math, I sort of did the back of the envelopes math, and it came out shocking to me. And I started thinking, well, if this is the case, if physicians really are in the same category as the military, who's paying attention to it? Okay. And then I started reading a little bit about burnout and went from there.
Great. We'll continue to explore it. Let me give Simon maybe a chance to introduce himself and tell us also how he got.
Thank you. Well, my story is that having spent time working both overseas and now in the United States, as I continued my career, I've noticed frustration and symptoms of burnout, people with depersonalization and lack of empathy and frankly frustration in many colleagues in many different areas within my work. And my concern as I've gone through talking to people is that the ideas of a lack of resilience didn't really resound with people. They didn't explain why people were feeling burnt out, and they didn't explain how to fix the problem for people. And so as Wendy and I began talking about the suicide issue and the issue of, for want of a better term, burnout, we started to hit on this idea that there was more to burnout than just a lack of resilience, and that's where this concept of moral injury comes in.
Okay, so we'll get into your viewpoint, but again, give us a little bit. One of you, maybe Wendy, sort of the overall epidemic features. When did people start talking about physician burnout? How many years ago? And is it increasing? Has it always been high but under-recognized? What do we know about those features?
So I think physician burnout as a term and as a concept probably has been talked about for a decade or more. And it's been an academic area of study for at least that long. But despite really closely following it, and institutions like the Mayo Clinic acknowledging it and trying to address what seems to be a growing epidemic, more and more the numbers and the percentage of physicians who are suffering and struggling with these concepts or these symptoms of the depersonalization and demoralization and lack of enthusiasm, that has continued to grow steadily, not exponentially, but it has steadily progressed to the point where there are almost 50% of physicians who suffer at least some symptoms.
Okay. And what is this attributed to in the mainstream literature?
So I think for the most part, most of the literature perceives it as a failure of physicians' resilience. So that physicians aren't attending to their own self-care, and they aren't working sufficiently in teams, and they aren't relying on sort of good career hygiene or good really good self-care.
Right, good self-care. Yeah.
Go ahead. I was going to say, I think there's one other thing that comes up when you talk to people colloquially about this, and that is that the term burnout suggests that people are working too hard. And we've had some feedback from people that say, we don't understand. Why don't people just work less hard and take more time out with their families and things like that? And I think that the concept that this is about just too much work is not entirely encapsulating the fact that you can work very hard without necessarily burning out, but you can also work not necessarily nearly as hard, but burn out due to some of the frustrations and catch-22s in our system.
Right. To your point, I just have with me the current issue of the local medical county, San Francisco Medical County magazine, and they have a piece on burnout and how to prevent burnout. And they have a table quoting, research from some academic center here. And so the prescription here to prevent burnout, I'll give you some examples. They say, knitting, why don't physicians do a little knitting activity, yoga, healthy cooking, coping with stress, right? So book club, adult coloring, deep pricing. So anybody who's, either met somebody who's suicidal or treated somebody who's suicidal or depressed or whatnot knows that you don't, cooking and knitting, and it's all, I have nothing against knitting and cooking, but it's, you get a sense that there's something's missing here, right? There's, go ahead.
I think this gets to our point, which is that yoga, healthy cooking, having hobbies outside of medicine, these are all things that physicians do. And physicians are incredibly resilient. You don't get through medical school, you don't get through undergraduate and medical school and residency without building in a substantial amount of resilience. And so doing more yoga and more knitting and more healthy cooking and going on retreats, I think physicians would all like to think that that's going to work, and they try very hard, but really you're wedging in more requirements around the edges of already very precious time.
Right.
Away from that.
I think we would also, I think one of the other things is that we very much acknowledge that healthy exercise and healthy eating and spending time with your family and the activities you enjoy are honorable, worthwhile things to do. And there's certainly ways to manage burnout to some degree, but they don't hit at the core root of what's going on. They don't hit at the reason why people are feeling burnt out, and they don't hit at the reason why people have what we're now talking about as a moral injury.
Okay, so tell us. Go ahead, Anish. Yeah.
You know, I loved the piece so much because it really encapsulated something that I felt, but you know, you guys did a great job of clarifying it in words. This idea that that what's going on, and what maybe a better way of describing burnout is this idea that it's that physicians, you know, are failing to connect in a way with their patients and with their community that was kind of the injury. So it's not and that and you nicely connected that disconnect with the inability to provide high quality care, the inability to do what it is most of us went into this do, which is to heal. And so I thought that was really, really wonderful. And I wonder if, so immediately, of course, my bias is that I see a lot of protocol method driven medicine, and that kind of seemed to kind of go hand in hand, right? Meaning when you have physicians that are being asked repeatedly to kind of follow X, Y, and Z protocol, and therefore they aren't quite connected to patients, and not just protocols when they relate to whether it be sepsis or whatnot, but you're asking physicians to have priorities that aren't necessarily related to the individual patient in front of them. So whether it be, checking boxes for, whatever, aspirin use or statin use, or whether it be making sure that you code as many ICD-10 codes as you can, so your expected mortality numbers, are appropriate, so you'll get the right U.S. News World report ranking. And all of these things, it seems to me, when physician leaders or administrators stand up in front of the physicians and go through these things that we have to do to have to make for a healthy health system, it seems that physicians just seem to go along with it. So I wonder if part of what we need is enlightenment on the part of physicians to not necessarily go along with this type of system-based care that doesn't necessarily prioritize the individual. Meaning, are we, in some senses, part of the moral injury to ourselves? I mean, are we? Is this a self-inflicted wound?
Well, let me, Anish, I'd like to interrupt here before. But Wendy, why don't you? I think Anish touched on the thesis of your essay, but can you give it to us in your own words? Exactly where you think the problem arises. This problem of burnout.
So I think where it really comes from is this sense that physicians are trying to serve too many masters. So we're caught in a double, triple, quadruple bind of trying to satisfy the requirements and the needs of our patients, who should come first, but also the insurer and their needs, our health insurance system and its needs and constraints and requirements, and also our own self-interest, because at this point, oftentimes a physician has a quota that they have to meet, or they have other constraints that drive their bottom line. And so trying to satisfy you can't just satisfy one of those. You can't just attend to the patient and do a good job. You have to attend to the patient and the insurer and the healthcare system,
right,
and your employer and your own self and family.
And the advantage of that thesis is that over the last 2-3 decades, the number of competing allegiances has increased. So, I mean, physicians have found themselves more and more in a situation where they have to satisfy more and more third parties or outside parties besides just the patient.
Correct.
Right.
Yeah, to go back to Anisha's point, there are so many different competing interests, from the electronic medical record to the insurance to the protocols that you mentioned, prior authorizations for the insurance, a requirement for RVUs, maximizing or minimizing readmissions, reducing hospital stays, improving online reviews. And while some of these things are done with good intention and some of them aren't intrinsically bad, of course, a great electronic medical record system should save us time and improve patient care. The catch is that most of these things start to erode the physician-patient relationship, and it's eroding that relationship that makes it hard for physicians to feel like they're really healing their patients. It takes away from their sense of healing patients, and that's where this comes from. That's where this injury comes from that we term burnout.
And I think the other side effect of that erosion, and patients are becoming more and more aware that we are not always attending to their own best interests, because they are realizing that we have these other masters that we have to serve, and that's causing them to not trust us.
Right.
And so it's really coming to a horrible erosion of that doctor-physician, that doctor-patient relationship.
Right.
So why are we? So I mean, are we complicit in this? Meaning, why do we? I'm constantly surprised that we go along with so much of this. Meaning, why are we? Yeah.
Before we get there, it's a very good point, Anish. But I want to complete here the thesis. So why call it moral injury, and where does that concept come from?
Moral injury is this concept that was developed to explain what happens to soldiers in war when they do something that goes against their moral fiber. It's a transgression against their moral beliefs. And physicians train for a decade or more specifically to take care of patients. And when you ask them every single day to make decisions that countervail against their patient's best interests in the interest of the insurer or the employer or the system, the hospital system, or any other number of competing interests, that goes against the Hippocratic Oath, and it becomes a morally injurious event.
Right.
Again and again.
Correct. I think that's a really, really interesting idea and concept. And so moral injury, you mentioned that in your article, is a fairly recent concept that introduced in military medicine to explain things like PTSD and that sort of thing. And I don't know if it's your article or the article that you refer to about moral injury mentions that the moral dimension of the profession, at least in the military, was overlooked as an explanation for PTSD and chronic depression and that sort of thing. And but you're right. We just had we just did an episode not too long ago with a philosopher about Hippocratic ethics and how they have been eroded from medicine, and how medicine is intrinsically an ethical endeavor. Right? You really cannot separate the technical aspect of practicing medicine from the ethical commitment that comes with it. And so you very nicely illustrate this sort of this conflict and this separation that becomes sort of inevitable and a part of day-to-day practice for every doctor in our current healthcare system.
Correct. And I think to Anisha's point, though, if you don't have the language And if you don't have the language to put on what's happening to you in that context of moral injury, it's impossible to understand what's happening and then to be able to change it.
Yeah.
We found this as we were writing this essay through several of our drafts, that as we showed our drafts to people, they kept saying, well, we don't really understand, you're reiterating the idea of burnout. And it wasn't until we changed the language and started using the term moral injury that people started to understand that we weren't just talking about a lack of resilience among physicians.
Right. So Anish, you were asking, I think, a very good question. Why are physicians going along with this?
Yeah, because when you're talking about it's a great analogy when you talk about the military. But of course, these are folks that are being sent to war. I mean, they don't have a choice. They're not conscripted anymore, but they're kind of put into these arenas, put in these theaters where people are shooting at them, and they have this stuff going on here. Yes, we are going to an arena where we have we're surrounded by all this medical very sick patients, and patients calling us at all hours of the night, and that kind of mental load of dealing with somebody that's sick. But I just would love to. I mean, I understand why it is we as a profession seem to be going along with the overlords who prioritize. Clearly, it's obvious to all of us, right? That these priorities that are being set for us, whether it be clicking X, Y, and Z on an EHR, or whether it be making sure we code better or whatnot. All these things that are not patient-facing things that we went into medicine to do, and that don't have that isn't that where healing is not the intention or the priority, certainly. Why do we as a mass of physicians simply go along with injuring ourselves?
Nisha, I think there's three ways to look at that. I think the first is that there are relatively few choices. When you're a physician, you're not given an enormous number of choices that allow you to avoid the system that we're in. I think secondly, some of this happens very insidiously. The vast majority of physicians go into medicine with every good intention, and if you talk to almost every medical student, they say they're doing this because they want to help people. And I think that keeps some people blind to what's going on to some degree. And I think until recently, we haven't talked about this. This is the third thing. When we don't have the language to talk about, or we don't acknowledge it explicitly, then it tends to be easy to walk into this without realizing it.
So, I also think that just one other quick thing is that much like an 18-year-old recruit going to war, the reality, the idea of what you're going into for either medicine or for the defense is very different than the reality of the practice of it. And I think neither is prepared. Neither the soldier nor the physician is prepared for the actuality of what they get into.
Right. Yeah. And perhaps before we get into how to better prepare ourselves, is this unique to the U.S., or what's the physician burnout or moral injury issue in other countries where possibly they may have similar competing allegiances?
So I think the short answer to that is, although neither of us work outside of the U.S., we had a deluge of emails after this article was published and read internationally, and we certainly had a large number of communication with people in other health systems and in other countries who said that this resonated with them as well, including quite a number who were suffering exactly the same problems that we're dealing with here. Right. So I think the short answer is, yeah, this is not unique to the US. We certainly have some things that are unique to the US, and certainly some things that make this trickier, some of the financial arrangements for sure. But there are certainly competing allegiances in many systems.
Is this something, do you think, that's unique to large health systems? Meaning, is it something that would you say that this is something that, or say employed physicians, physicians employed by large health systems specifically? Is this do you think it's more of a problem in that arena?
No.
I think the more competing allegiances you have, the harder it is. But I think whenever you have aspects of your practice or aspects of your profession where your ability to care for patients is impaired or taken away from you, or however you want to put it, things that impact the physician-patient relationship, this happens. So it's certainly worse when you've got significant financial implications or professional implications, but I think it's in many arenas.
That's interesting.
Mm-hmm.
Sorry, go ahead, Wendy.
I live in a rural part of Pennsylvania, mm-hmm. and we're in the midst of a primary care physician crisis because most of our physicians are leaving.
Right. Yeah, it seems interesting. The one kind of spot where folks seem to be happier appears to be these small little these little groups that are springing up. Where physicians are kind of unplugging from the current system and the incentives that the current system, these perverse incentives that the current system kind of forces, these 15-minute visits and making sure that you check off boxes so you don't get a penalty for Medicare. And so these groups that are kind of emerging, who essentially are cash pay groups, the direct primary care movement. I don't know if you folks have heard of it or what, but it would seem like these are folks that when they unplug from the system and therefore unplug from these perverse incentives that we're talking about, and now all of a sudden they're incredibly committed. It's just them and the patient, and no insurance folks. They run their own practice. Do you think that is at least not that there's any one particular solution to this, but do you think that's one path that kind of would make you immune to some of the injury here?
So that's how I practiced psychiatry for about a decade. Mm-hmm. And it certainly makes it much easier to practice, but it is almost impossible to completely disconnect from the insurance system because patients, they pay for their insurance. They want to be able to use their insurance where they can. Right. And if it's just simply an office-based practice and you're just seeing simple conditions or preventative care, then it's a reasonable model. But I think when care becomes much more complex, it becomes harder and harder to continue that model.
Okay, so let's that brings us to the next maybe aspect of either prevention or of this moral injury, because one could think about it in two ways. One is the one that Anish alluded to, is that trying to unplug from the system, but that's limited so long as there is a system, a large system. It's limited in its effect and reach. And the other one, I think, is something that you suggest, but I want you to elaborate a little bit more, is to make the leaders of the system more aware of this, so that somehow they, first acknowledge these conflicts of interest and then deal with them. But I'm not sure what that looks like. What are your thoughts, or do you have thoughts about beyond just recognizing what the issue is?
Well, I think that absolutely the first thing is acknowledging the problem and recognizing the problem and accepting that this isn't something that can be ignored. And so accepting that there's a human cost to this and, frankly, a patient cost to it, I think, is the first step, especially with these large health systems where that's important. I think we need to make sure that patients know that this is going on, because they need to be able to ask for care which is independent of some of these conflicting allegiances. We need to make sure that insurers be as moral and ethical as they can possibly be within the bounds of being a business enterprise. And we need to do our best to have hospitals recognize that there's actually a business cost to them not acknowledging this. taking care of your doctors is also taking care of your patients, and taking care of your doctors ultimately saves you money in terms of physician turnover and patient care. And so giving those physicians respect and autonomy to do what they know to be best, and to make good, evidence-based, if necessary, rational and safe decisions, is part of keeping those doctors and part of taking good care of patients. So I think, yes, you do need to answer your question. Yes, you do need to start by acknowledging it, but then giving these opportunities is a very important part of creating a win-win situation, creating a system where physicians do well and patients do well as well.
So I think the problem is you're going to run into the buzzsaw of the physician MBA or just the MBA. You know, I'll just read you they just think completely differently from what you just said. So, you know, there's this whole thing about how do when hospitals buy practices, typically the practices lose more money than they would think, and they're like, so the question to hospitals, you know, the vexing problem to hospital executives is how do we make money out of these freaking physicians that we've hired, and now they're like lazy and sitting on their butts, right? And I'm just going to read you this fantastic paragraph in terms of how this particular physician MBA leader, I don't know if he has an MBA, he's a leader. He's the one that turned it around, and he figured out how to make these darn physicians profitable. All right. Our first action was to take control of the schedule away from the providers and to transfer the responsibility of booking patients to office managers who answered to the director of operations. Our second action was to increase the hours of operation by pushing the opening time to 7 a.m. and adding extended hours for most weekdays as well as Saturdays. We also opened the schedule to same-day requests and walk-in appointments, and eventually allowed patients to self-schedule throughout our patient portal. As a result of these steps, the proportion of time the providers spent on direct patient care increased from 59% to 95% of their contracted hours. I mean, that's a
fabulous short-term fix. That is a fabulous fix for this month, next month, maybe even the rest of this year.
Yeah.
But in the long run, they'll turn over physicians. That'll cost them a lot of money. They'll have patients who eventually recognize that they're not getting such good care. They may get after-hours care, but it won't be done as well, and their time slots will be reduced to shorter times. And in the long run, that's a fallacy. That's the problem. It's a short-term fix.
That's a wonderful way of putting it. Because he specifically, the hilarious thing is later on in the article, this gentleman goes on to say that, you know, we implemented this stuff, and initially there was some resistance, but we were firm about it, and 20% we let go, or they refused to comply, and so they went away somewhere, and we replaced them with fresh new young bodies, and and because we had changed the culture to be so systematic, we got some of the top recruits from all these different places.
I think that also demonstrates another important point, which is that within our system, there are some senior people who are extremely valuable, who have knowledge and insight and intuition that cannot be replaced by new recruits. And if we alienate those people, we're losing an enormous and very valuable resource. If you want to look at it in business terms, they are a resource who will walk out on us. And we need these people. And so it's not just about warm bodies, it's about quality of the bodies.
The problem over and over again, I'm just in my short, I'm reasonably, I've been practicing for about 8 years or so. And just in that short period of time, I've seen over and over again, this idea that the physician as widget, right? Meaning you'll have a very successful, say, heart failure group, and some new person, some new head of some administrative thing will show up and will be not happy with X, Y, and Z, and will start making some type of draconian rules, and it will destroy that entire heart failure group. And this group of highly experienced, they've been doing this for 15, 20 years. They have deep referral lines, networks, successful program by most metrics. And suddenly, within 2 years, everyone has left, and they're replaced by these much younger, much less experienced folks, and that the program is destroyed for a decade.
Right. But, in defense
or worse yet, they don't leave. They stay because they're trapped, because their family is at a point where they don't want to leave, and they unplug, they disengage, and their patients suffer. as a result.
Right.
But in defense of the MBA guy and the bottom line, I mean the truth is these groups that's on the surface were functional and whatnot. At the same time, were financially unsustainable. I mean, there's
right,
and the problem is that it seems to be inherent in a system of third-party payments and third-party regulation and whatnot, that these conflicts are going to be there, and they affect the competing allegiances are not just negative towards the physician, because the physician is also benefiting from this arrangement, right? I mean, there is at the end of the day some job security and some income security of being a physician in the system that physicians benefit from, and likewise for the patients. For the patients, there's there seems to be a benefit in thinking or assuming or holding on to the promise, whether the promise is true or false, but the promise that somebody else will pay for the care, right? So it seems to me that this whole idea that we can have systems of somebody else making decisions, somebody else making footing the bill and whatnot, unless we deal with that, I don't know that we can have any kind of solution. There's a sentence in your paper that I really like at the very end. It says, "A truly free market of insurers and providers, one without financial obligations being pushed to providers, would allow for self-regulation and patient-driven care." And I think it's a little bit ambiguous here, and I don't want you to commit to any kind of particular solution. But in my mind, I mean, I think so we see this problem of competing allegiances and burnout in different countries, not just in the US, but other places as well. And we see all these healthcare systems to various degrees sort of incurring more and more debt and being on an unsustainable path. And that goes not just for the UK and Canada and here, but also for Switzerland. We had a guy, who was telling us about the healthcare system of Switzerland. That's also unsustainable. And there, there's more of the MBA types, who are trying to regiment how physicians are behaving and so forth. So I'm not very optimistic about just, acknowledging the problem and then letting leaders help us figure out a solution. I'm wondering, Wendy, what is the military doing about its own situation? Or is it doing anything as of yet, or is it too early to tell?
Doing about its own situation of the physician crisis?
With the moral injury question, which, that was the analogy, which you mentioned, since the soldiers are
right.
I mean, now there's a realization that there's an ethical component to this moral injury. To this PTSD, right?
So I think moral injury is a very complex problem, and it does not lend itself well to research that happens in aliquots of 3 to 5 years. And so I think the military has acknowledged that moral injury is an issue. The conversation has been rejuvenated over the past 3 to 4 years, and there are small pockets of treatment focusing on the moral injury from the recent conflicts. But right. We certainly aren't. The military has not gotten out in front of it and doesn't have good solutions.
Yeah, it seems to me that there's a parallel, because just like, to me, the healthcare systems are, at a fundamental level, in a way, unjust in what they're trying to achieve. I think, and again, maybe I'm taking a political stance here, but I think countries are participating more and more in unjust wars, and therefore the soldiers are bearing the brunt at the level of the conflict and being sent there of these moral injuries, and so unless we take a step back and look, if it's a system problem, really it's the system that needs treatment, and that's where the solution needs to come from.
Well, at the very least,
So I think.
Go ahead, Wendy. Sorry.
So I think both of these are analogous. That the military is just coming to the language to speak about moral injury as our physicians. And until we start talking about the right diagnosis, it's very hard to come to a treatment.
Right. And I don't want to take away from actually your very valuable contribution. I think this is very valuable. So you're right. I mean, on the one hand, I'm saying here that I'm not optimistic and so forth, but it's, you're right. I do want to say that this is, it certainly is the place to start, and a very, very important place, and a big departure from what we've been hearing so far, for many years.
At the very least, I mean, Wendy and Simon, you don't know that Michelle is an anarchist who wants to blow up everything. So you didn't realize that on the show. But at the very least, I really, really think, I really believe that I think a lot of this relates to physicians losing control of the system. Meaning, it's now these decisions have been taken out of the hands of, 20-year veterans who've been doing this who are physicians, who are healers, who understand what the priorities are. If they are physicians that are in leadership positions, the physicians very much so have marching orders to understand that, hey, what we have to do year to year is increase the number of outpatient visits by 20% year to year. Those are the metrics now that the chairmen of X, Y, and Z kind of, walk the line of. And if you don't walk that type of line in this environment, then, there's somebody else that's waiting to take the reins. So, whether we blow up the system or not, I really think that, physicians in whatever way regaining control is going to be key in terms of trying to help this. Now, but the problem, of course, is that given the dollars and the financial stuff at play, we also then would have to take ownership for that, and that's where we get into this political argument about how exactly one goes about doing that. But outside of that, I also noticed that I'm on this theme of physicians injuring ourselves. I noticed that there's a ton of fractious stuff going on just within the physician community itself, right? I notice, and I'm sure you guys have noticed, Wendy, especially, that physician suicide, for instance, has a remarkable predilection for males. Is that what you've? Is that correct?
Actually,
or you
no.
Don't think so? No, you don't think so.
No, actually, so yes, there are more men who complete, but when you compare the male incidence in physicians versus the population,
general population.
And you compare women, the women are about 2.5 times more likely to complete than in the general population. Men are about 1.5 times, a little bit more than that. So really, female physicians are killing themselves at a much higher rate.
I see. So there are many, many, many more male physicians that actually complete suicide, but you're saying the rate of it is much less. Meaning by numbers, there's like, it's like 7 to 1 or something. There's 7 times. I mean, it's hard to get at these numbers also. But Pamela Weibel has a site, and at least her database or whatnot, it looks like it's 7 to 1. Meaning there are 7 times as many male physicians that actually complete suicide versus male physicians. But you're saying when you relative to the general population, I guess because there are many more male physicians out there practicing, that rate is still more for women.
No, so the suicide rate in the general population is higher for men,
right,
than it is for women.
I see. So
if you compare rates, the male physicians and the male population, male physicians is slightly high, maybe 1.5, 1 3/4 higher than the general population. For women, it is 2.5 times higher than the general population.
Right.
I see.
It is a complex issue. I just want to, before we close, I want to come back to this issue that, nevertheless, it seems plausible that I know Pam Weibel. We were speaking of her. She focuses a lot on the training and the work conditions being terrible, and medical school is pretty yeah, I mean, we many of us survive it, but it's pretty silly, brutal in a silly way, right? Um, do you think that's there's something that could be done there, or is there, or do you think that it's really it's missing the point to focus on these kinds of work conditions?
Certainly, there's an importance about starting early and making sure that our medical students understand what they're getting into, and making sure that they recognize they have a voice, and making sure as they go through this that they continue to place the physician-patient relationship at the forefront of what they're doing. There's no question that working at that level is very important. But we do have a lot of education to do for those of us who are well into our careers and people senior to us, so that we're all working in the same direction and rowing the same boat. So yeah, I think it's worthwhile, but it's not the only thing to do.
Well, it's been a very interesting conversation, Wendy and Simon. Thank you very much for joining us. We'll link, obviously, to your piece on the show notes at accountandcoca.com. For people who haven't read it, I really highly recommend it. I think it's very thought-provoking, and I think hopeful, because, as you said, it's important to understand what's actually going on. And we look forward to perhaps reading more. Do you plan on doing more on this topic in the future, either one of you? Wendy?
So, I'll let Wendy answer.
So we, being surprised by the response to this, we decided that we really need to start organizing around it. And so we are setting up a nonprofit, and we published our website yesterday.
Oh, great. Well, let us know, and we'll link to that as well on the show notes. You can
absolutely
communicate the website, or you can give it now for people who, is there a name?
Yeah.
It's www.moralinjury.healthcare. And we'll get it to you so that you can put it up on the show notes.
Okay,
that would be
perfect.
Great.
Well, very good. Well, we look forward to following you there as well, and see what happens. So,
thank you very much. This has been terrific.
Okay, thank you very much. Have a good night.
Alrighty, take care.
You too.
You too. Bye.